Hello everyone, my name's Mo.
And I'm Camille.
And welcome to the Pareto podcast.
You're definitely going to enjoy this episode.
Absolutely.
Welcome back, guys. Episode 2. Back at you again. Camille and Mo. Nice to see you back.
Yeah, nice to see you all. Nice to see you. Nice to see you, Camille.
Exactly.
How's it going? How you been?
Yeah, I'm keeping well. Steady away.
Yes. No, absolutely. How's work been? How's your week been?
Yeah, not too bad. Busy. Working in a hospital, gastroenterology ward, as you know. So dealing with all kind of problems and issues and medical issues that arise from pathologies of the gastrointestinal system. So, it's definitely interesting. It keeps us busy. Practical side, and also, in terms of dealing medically as well.
Yes.
There's a few aspects of gastroenterology that I'll go into on this episode as well, in terms of what day-to-day life is about, what kind of procedures, practicals is, and also other things as well, wider-wise, how we deal with the particular subsect of patients, challenges that arise, and that kind of thing. Yeah,
no, it's really, gastro patients honestly really scare me sometimes because they can sometimes look all right and then they become sick very, very quickly.
Absolutely.
Obviously, I get a taste of that in accident emergency, but you kind of do more of the managing and really dealing with some of the repercussions of their presentations.
Yeah.
And I understand gastro to be quite a comprehensive specialty. Is that?
Yeah, you are dealing with a lot. We deal all the way from, the diseases associated with the mouth all the way to the back passage.
One end to the other.
Yeah, which is a polite way of putting things. So we deal with a wide variety of things, whether that's, bleeding patients such as upper gastrointestinal bleed, lower gastrointestinal bleeds, liver problems, gallbladder problems, although the surgeons do help with that. And also things like inflammatory bowel disease, ulcerative colitis and Crohn's make a big workload.
Yeah, I can imagine. See a lot of those patients in A&E actually.
Yeah, unfortunately these kind of conditions do flare up. Flare and remission, that's sort of a typical cycle. A lot of the things are chronic conditions as well. So we're trying to manage them. It's very difficult to sort of completely cure these patients. We don't have any sort of pills or surgery that can completely cure someone of. It might remove the diseased element of the bowel, but then people are left with stomas and things such as that. So, which are new fashionings of, how should I word it? Where they can empty the bowels.
Yeah, I guess.
So into the via
a pouch almost.
What's the actual thing called? The opening.
The stoma opening.
Yeah, via the stoma rather than through the back passage, which is natural. So these kind of things. So we are involved heavily with the surgeons.
Yeah.
But some really interesting drugs. Some of the new biologic drugs as well.
Yes. No, I get that.
So it's quite interesting and definitely keeps us busy.
No, good. We're gonna hopefully talk a little bit more about that. Before we get into the meaty aspect of it, I thought I'd start off with a story.
Yeah. Why not?
I think our line of work brings some interesting cases and some stories, so why not? I'll start off with A&E in A&E in the resuscitation area. This patient who came in with proper left-sided chest pain. He actually worked at the hospital.
Wow. High stakes then.
Yeah, man, absolutely high stakes. And he was actually coming into work. He'd started with the chest pain the day before, but he just thought it was all right. He was actually fit and well in his 60s, quite active. Came into work, drove in, and collapsed at the door of the hospital.
Wow.
He was brought into A&E. He was brought into the ambulance area by some of the ambulance paramedics that were outside, and then they did an ECG, and lo and behold, it's probably the most clearest ST elevation I've seen in my life. you know those textbook kind of clinical schools, kind of like examination based ones where you get those really typical ST elevations, and the diagnosis is really obvious in the SBA question. Is one of those ones actually. I looked at it and I thought, yeah, it can't be anything else. There's no doubt. Anyway, because where I work is not the primary centre for cardiology, so I had to call the regional centre, which would be Leeds in this instance, and had a conversation with them, and then said, look, this guy's got proper big ST elevation, inferior lead, myocardial infarction. I've given him the starting medications.
Yeah.
I think you need to take him as a patient. And they said, that's fine. You need to transfer him via blue light ambulance straight to Leeds. Anyway, the chap was all right in huge amounts of pain. I gave him morphine, gave him all of the stuff. Still in lots of pain, clutching his chest, lots of issues. And we made a decision that actually he's probably going to deteriorate very, very quickly, and someone needs to go with him in the ambulance. And that someone was me. So anyway, we went via blue light ambulance, went across heavy traffic.
Yeah.
Lots of horns, lots of blue lights.
All the problems.
All the problems, man. All the problems. But got there faster than I'd ever expected, to be honest.
Okay, that's good.
Managed to get there, but you know what? It became really tense. So I was there on standby, whether the patient needed shocking or not, if their heart stopped working, essentially. But he started to get really restless, really short of breath, just all over the place, to be honest. And that was because his heart attack must have been so significant, it just put him into absolute heart failure. So he was getting really sweaty, short of breath, couldn't lie flat. We got to the hospital, we wheeled him in, we went upstairs to cardiology, and he arrested. He had a cardiac arrest at that point, and jumped on his chest, started giving him compressions. It was really, really tense. By that time, anaesthetists were there, and cardiology consultant was there, and registrar was there. Anyway, they managed to bring him back. They intubated him, and he arrested again. And this was the moment. This was an awesome, I never really thought or imagined something like this was going to happen. He was arresting. He had arrested. They were trying to stabilize him, trying to bring him back to life. They took him to the cath lab. They started primary PCI, so they started to put a catheter in through his groin, started to wheel it up, go up into the coronary arteries. And then they managed to find the blockage, and at the point of stenting it and opening it, he came to.
Wow.
As in he got a pulse again.
Wow.
And I was like, wow, they literally, and probably in the most truest sense, they literally saved his life.
Wow. That's amazing.
That was pretty crazy, man.
The NHS at its best, I think.
That is NHS at its best, absolutely.
Accident, emergency, all that process, the amount of resources, the amount of people, the amount of, specialist involvement in that case to save that man's life. Wow, that's amazing, And I hope he's doing well now,
Yeah, no,
continuing on that rehab, because we often see in acute cases, we might just save the patient, but it's the sort of post-recovery phase, which is very difficult and often lasts months and months.
Absolutely.
But wow, that's an amazing case, and
it was
learning points from that.
Honestly, it was. I thought, I thought everyone played their part.
Yeah,
I think,
yeah.
The paramedics played their part.
Yeah.
I think A&E did as best as they could. Cardiology played their part.
Yeah.
Anesthetics played their part. The cardiac nurses were fantastic, to be honest. And it was a really, really good case. But I want to actually pick up on what you said, to be honest. And I think this will probably allow us to segue into the bulk of the conversation. You mentioned about the importance of follow-up care, comprehensive care. Tying knots and ensuring everything's all right. From your experience, and I know you're in a ward environment as well.
I am, absolutely.
How much of a difference does that make to a patient's experience?
To be honest, I think right now at the moment the NHS is struggling with that. We're very good at treating the acute things, putting the life-saving interventions in place, and perhaps stabilizing patients from that point. But the difficulty is becoming afterwards, when we sort of stabilize the patient, getting them back to a standard of living, quality of life that would be acceptable to the patient. And sometimes we're met with sort of unrealistic expectations from patients. there's severe, health burden based on their, unfortunate comorbidities, their other illnesses. And the patient is not quite ready to accept that this is their new sort of baseline function.
Yeah.
It's oftentimes you see after stroke, for example.
Yes.
It's a very long, arduous process to get the patient back. And sometimes we never get there. And that's something it's quite hard to accept as a clinician. Also in terms of, sometimes if patients require extra support, acute hospital settings are perhaps not the best way to achieve that. See all the time in gastroenterology patients, often these patients, unfortunately, there are some elements of, poverty levels are quite high, unfortunately. Their housing environment is not safe. They're not able to sort of keep themselves safe and also in that habitable standard of environment of living. So then it's about in terms of getting that up to scratch and also giving them some sort of support. Now currently there's big waiting lists for social support services, and from our side, from the ward side, that's what we see that again and again. Patients unfortunately becoming having to spend much longer on wards than medically required because the social side isn't there, the rehab side isn't there, the district nurse as setup isn't arranged yet, the carers aren't ready. And that's something we struggle with again and again. And, it's something that I definitely see in terms of the NHS where we get the acute stuff, we stabilize the patient, get them to the point, but it's that afterwards where it's a long, arduous process, it's an expensive process. It requires many different multidisciplinary teams, whether that's occupational therapy, physiotherapists, general practice, which is under huge strains at the minute. For sure. So that's where I see, how we're struggling at the moment. And obviously this causes a knock-on effect. If a patient is, for example, medically fit, we call the term medically fit for discharge. So medically we've stabilized them, but we're just waiting for the other aspects, like I mentioned. And this has a knock-on effect because that bed is then taken by that patient and we can't get that run through from A&E or like in a medical assessment unit or even a surgical patient. So that's where the difficulty arises.
No, I get that, and I think there's, you've given a lot to unpack there, to be honest, which is good. I remember speaking to a colleague that actually graduated from an international country within the developing world, and I just wanted to ask and pick his brains about how medicine was practiced there and how things were done there. And he said something really interesting. He said the good thing about, he said the positive thing about the NHS is that it's true to the research. I was a little bit taken back by that. I said, what do you mean by true to the research here? And he said, because he goes, where I come from, and I'm not going to mention where he comes from, but he goes, where I come from, he said, we're really good at dealing with the issue. So if someone comes with someone has broken a bone, requires surgery. Someone has got hepatitis, requires some medication. Someone has got Crohn's, ulcerative colitis, someone's got an acute medical issue, we can deal with it. It's not a problem. Very efficiently, very well. But we know that in terms of the research, your health is determined by so many different things. You obviously mentioned a few of those, social housing as an example, where you're living, your health behaviors, outlets and help to different services. There's so many different, it's very multifaceted. And he said, where I come from, that's where people are failed. That's where the failure comes in, because there isn't any consideration for any of those different things. Whilst definitely in the NHS there is, there is an attempt to try and address some of those different things that affect. Would you say that's the case?
Yeah, I mean, definitely NHS unfortunately does become that safety net, which is good in certain aspects, but it's not exactly tailored to have that function where it can do everything for every patient. Unfortunately, it can't, one with the lack of resources, staff level specialists, funding, and in terms of, in different things, if I mention, especially on the mental health side, I think that's a big issue at the moment.
Massive.
With the NHS, in terms of, whether that's any eating disorders, which we definitely see on our ward, or whether there's other things such as like overdoses, acute mental health issues, psychosis, that kind of thing.
No, for sure.
And that's very, very difficult to deal with. Requires a lot of time, patience, resource, and also allocation of real resource and time.
For sure. I mean, it's really stretched, isn't it? As in, there's probably not a day in my practice where I don't see someone who's got quite severe mental health issues, whether that be anxiety, whether that be depression related, or more severely psychosis. And recently, especially where I'm working, there have been a few patients that have required sectioning. And the sectioning is so important for them because they're obviously at a threat of their own life or someone else's well-being, but there just isn't enough of a service that will help to keep them. So some of these patients are being transferred, across the country to the other side of the country because that's where the only mental health bed is. And it's painful, isn't it? Like, because you know how vital these things are, but there just isn't enough of a service to provide them.
So when you talk about sectioning, you mean mental health?
Mental health sectioning, mental health sectioning.
Under the Mental Health Act, someone would be unable to is currently not having the capacity or insight into what they're doing. So for their own safety and their well-being, we need to sort of treat them sometimes against their active will at that moment in time, perhaps admit them as an inpatient. So that's what it means of sectioning. There's different levels to that as well, in terms of how long the duration is, what kind of things you can do with this patient. And there's levels of protection for the patient as well, in terms of perhaps getting some family members, next of kin involved in that decision, an independent mental health practitioner, an IMCA. So these kind of things, but it's very, very difficult. So in terms of the broad NHS, there's so many different things that it can do. And like I say, is that final sort of safety net for patients, vulnerable patients. And sometimes stories are really sad, patients don't have any next of kin. Perhaps they're from a different country and they're in this country and, there's no ties with anyone else. They don't have that friendship group that perhaps me and you enjoy. So, they lean on NHS services a bit more than the average person. And, it can be really difficult, in terms of getting these people, these patients, the right support.
Some people are just, as difficult as it is to say, but some people are just lonely.
Very true.
And they come not to seek company, but to seek at least somewhere where they can offload, have a conversation, because unfortunately there isn't really anyone that's looking after them, or they aren't able to have a conversation with someone.
Absolutely. I do see that a lot with my general practice colleagues. And also GPs, but also physician associates working in general practice. Nursing colleagues working in general practice. They do see, elements of deprivation, but also, loneliness, like you mentioned, patients not having that family support. And we can, research shows that loneliness is, can be as bad as smoking cigarettes, 15, 20 cigarettes a day.
Okay, wow.
On their mental health, but also their physical health as well.
Wow, I didn't know that. That's
just
good.
with, being deprived of that, humans as a nature, we're social beings.
Indeed.
We need that connection, we need that love, warmth, affection from others, and also to feel that people support us, care about us, that, we're valued members. And, it's very sad to see certain patients not being able to enjoy that, which I think is a key part of life.
No, it's true. It's true. Can I ask a question?
Of course.
Just out of interest, because I know you're... because the ward environment is very different to the A&E environment, as in in A&E we're usually really responsible for we've got a set amount of time, find the issue, diagnose the problem, take your bloods and do your x-ray quickly, and work and make one decision: is this person coming in or is this person going home? That's basically the specialty in a nutshell. And that's quite a difficult decision to make sometimes. But going into, we do try, but we don't really go into the nitty gritty, the depth, not only of the medicine, but also the depth of, the circumstances and the different issues. One thing I've definitely struggled with is kind of helping to counsel patients on health behaviors.
Yeah.
So I know in gastro, you probably get certain people with certain health behaviors that they have that's really contributing to their repeated presentations, admissions, etc. What's your experience dealing with those types of cases?
So it can be difficult. I can see what you're sort of alluding to. And for example, the typical, unfortunately, especially if I'm talking about liver, cirrhosis, that kind of thing, it's definitely a typical patient would definitely be a heavy drinker with a heavy alcohol intake for many years. Now, the liver is a remarkable organ. There is an element of the liver being quite robust and resistant to that damage, but it can only tolerate that for so long until there's sort of permanent scarring, which is known as cirrhosis, and that can affect the function of the liver. Now, the liver has so many functions, and it can affect your well-being. You can often see these patients jaundice. That's one of the first things you probably see, looking a bit yellow, feeling unwell, sick, maybe feverish. Oftentimes you see them with big bellies. That's unfortunate, a complication as well. Develop a fluid in the abdomen that's known as ascites, can get infected. When patients in these sort of stages, they're not eating very well, they have no appetite, so that can affect their sort of electrolytes, that can make them more unwell. So it's a very vicious cycle that you want to kind of, and at the fundamental level, the core being is oftentimes the excessive alcohol intake. You're right, we do try and, once we've got to stabilize them from that, oftentimes it's requiring medication, whether that's diuretics to get fluid off, water tablets commonly known as, or a drain to perhaps get the fluid off the abdomen, improve their diet, fix any electrolyte imbalances such as potassium, these kind of things, magnesium often, get the dietitian involved. But once we've got all that and sort of stabilize the patient, we need to counsel this patient on not drinking alcohol, and oftentimes it's very, very difficult. Oftentimes their their socializing all revolves around alcohol. Oftentimes they are lonely. Oftentimes that is their one outlet which they enjoy. And alcohol is so freely available and quite cheap in this country that unfortunately it's quite difficult. We see adverts for alcohol freely available in supermarkets. It's very, very difficult to avoid that temptation. And it's not our job to judge these patients. It's to advise them best in terms of what kind of complications they can lead, and often it is life limiting. I see patients, unfortunately, very, very sad, but pass away from alcohol-induced liver cirrhosis in their 40s, in their 50s.
Wow, really?
And it's really not a nice way to go. Oftentimes they have sort of complications such as bleeding because their coagulation is affected, which is how thin their blood is. So once the liver is affected, it can make your blood more runny. So it has a similar effect to the anticoagulants such as warfarin and these kind of drugs. Has a similar effect. I'm not saying the mechanism is similar, but the blood is more thin. So you're more likely to bleed. These patients can have a massive upper GI bleeds and bleed to death, or vomiting blood, or losing blood in this way, and sometimes it's a very horrific death as well. And it's very, very difficult to sort of, not only that, but stabilizing the patient's promising not to drink alcohol, but unfortunately once they go back to the community, because of however many factors, resume drinking. Now it's not our job to judge, but like I say, it's definitely these many factors that would lead them to this.
No, for sure. I mean, it's very illustrative of the fact that something as simple in speech marks, I guess, in quotation marks, as alcohol can lead to, or in excess can lead to so many different things.
Absolutely.
And you're right, you mentioned something that we shouldn't be judgmental, because often there is a reason as to why these individuals are drinking so much. They might have gone through a particular life event. They may be, using alcohol as a means by which they can, make themselves feel better, deal with their mental health issues, whatever it may be. Or just born in a circumstance where alcohol is just seen as the thing to go to whenever you're kind of faced with any trouble. And we go by a certain code of conduct, don't we? We
Absolutely,
have duty of candor as an example. We maintain patient confidentiality. We remain impartial in patient care, and we try to basically care for them. I mean, definitely what I try and do is, you know, as well as alcohol, smoking also applies for like COPD, etc.
Absolutely.
So many patients come in with really bad COPD, lungs that are paper thin, you know, not expanding anymore really. Yeah. And they're still smoking, man. And it's like, they're still taking, you know, 15, 20 cigarettes a day, and, you know, on one side, but then on oxygen, you know, well, even though, you know, that's questionable, they shouldn't be on oxygen, but they've obviously twisted a few stories sometimes, and that's a different issue. But, you know, having to take inhalers, nebulizers, and all sorts of different things. And I can't help but saying, "You still smoking?" And then, you know, patient goes, "Yeah, I still am." And it's like, maybe you should really stop.
It can be frustrating. It can be frustrating, especially when you see the patients, the same patients again and again. It's often a story, and unfortunately, in my case, every time you see them, they're a bit worse. They're a bit along their prognosis, their prognostic. So we have certain scores that give an indication as to prognosis in terms of how long this patient, what kind of quality of life this patient is going to lead. And every time you see them, the bloods are a little bit worse. Clinically, they're doing a little bit worse. They're not able to mobilize. Their acidic fluid, their ascites is a lot more. There's shorter gaps between them needing the drain. And that gradual decline, sometimes it can be quick, sometimes it can be slow. And it's very, very difficult to manage. But that are the challenges of working in, I think, modern NHS, working in sort of medical specialties, working in gastroenterology in particular. But there are good things as well. I mean, we often see, you know, patients with, for example, bleeds. We can manage that, you know. We do scopes, so, you know, patients, you know, have a change in bowel habit. That's a red flag, especially in the over 60s. So if the patient presents to GP, they will send us to our department for endoscopy. We will scope the patient and we'll give them good news that, you know, no, there's no reason really, or there was a benign polyp that we removed, or anything like that. There's often good news, you know, or a patient will present with, you know, I've been taking pain relief, ibuprofen typically for some kind of pain that's developed an ulcer, which developed a bleed. We stem the bleeding with a scope, tell them some safety, and don't take this ibuprofen. We give them some gastro protection, such as Lansoprazole or something simple like that. And we, you know, the patient leaves happy, we've cured the problem, they solved. So it's not always about, you know, the doom and gloom. Sometimes there are positive stories like that as well, which we, you know, we deal with the patient from start to finish. We effectively cure them and send them home to live on, you know.
Good. I've got another question actually on this. You mentioned about, you know, sometimes your general practice colleagues referring patients in for changing bowel habits and requiring some investigations, and you feed back to them that this is what it was, cancer, polyp, whatever it may be. Do you talk to primary care colleagues regularly, and how close is your liaison normally? Yeah,
so there's different methods of communication depending on how urgent the query is. So oftentimes if a patient has been referred for example, a suspected, you know, bowel cancer or anything like that, we'll get the scope done or the biopsies, however we need to do the investigation, and a report is submitted to them quite urgently. Sometimes the question is more sort of urgent than that. So they're requiring sort of feedback sort of that same day or whatever, and in that way they can call in and ask one of our registrars or consultants a question. Oftentimes it's related to patients had some routine bloods and their liver function tests are off, for example, you know, and they just want to see if it's an urgent you know, need for admit to hospital, keep an eye on it, if there's anything that they'd want to do in this circumstance, and then they often ask for advice in that way. So I think that's one of the most commonest ones. Oftentimes there are set pathways, a lot of pathways in the NHS via NICE, so National Institute of Clinical Health and Excellence, and they will suggest to primary care colleagues in what if a patient in this age group presents like this, for example with dysphagia, so pain on eating, you know, this is the pathway. If they have these certain criteria, this is how they need to be referred, or this is how they need to be managed. So that helps a lot, to be honest, you know. And general practice colleagues, some of them are very experienced and they know how to deal with that, and then we can sort of refer them to them guidelines as well that would But if there's an urgent question, then you can definitely get in touch with us, and we would deal with that query.
Fine. No, sounds good. I think that's probably the crux of the conversation.
Yeah. We've talked a lot about the gastroenterology side and inpatient wards in particular.
Yes.
Perhaps on the next episode we can discuss about A&E in more depth.
Yeah, we can do.
And I can shift the focus onto you, perhaps.
Sorry, man. I thought you definitely had the more interesting insights this time around, felt more like an interview, but don't worry about that.
So we can ask you for some questions, and if anybody has questions, let us know, whether that's via any social media, Pareto. Let us know in the comments.
Absolutely.
Reach out. We're always happy to help.
Yeah,
we'll put some contact details at the end, and then you can reach out to us.
No, brilliant. We'll put all of the website and also our main social media and email onto the bio of this video. But thank you very much for tuning in.
Yeah.
It's been a really insightful conversation and sharing of experiences. But until next time, guys, thank you.
We'll see you later on.